Okay, I think this is a good time to start. So thank you everyone for coming. I'm not sure if maybe at the end of this we can take a picture of all of us.
Hello, perfect.
Yes,
This is
Gerard.
Dr. Gashema Heritier. So the presentation is about Marburg viral diseases in pregnancy. So the presentation has been prepared generally by me and some other colleague gynecologists and with Gerard. And as we all know, the outbreak comes started in Rwanda a few weeks ago. So not much known on hemorrhagic fevers in general in pregnancy. The studies that has been done was done based on case reports, some case reports from different countries. So the data we have is generally based on cases report, but I think the presentation will be helpful in case any of our colleagues in different hospitals may have a challenge case of like Marburg in pregnancy. It's just to have an overview to know how this case can be managed. And that's all about this presentation. So I can hand over the floor to Dr. Mbabazi. Thank you.
Yes, thank you very much, my senior Dr. Gashema. As it has been said, my name is Gerard Mbabazi. I'm a resident year 3 from the ECSACOG program. And together, of course, we managed to do this short presentation about what we know from the Marburg viral disease, especially in pregnancy and breastfeeding mothers. I hope I'm audible enough. Yeah, so basically, the presentation is just going to have a small overview, general overview in general about hemorrhagic fevers, especially Marburg in just any other population. Look at the transmission and the timeline. Look at the symptoms, the way it's diagnosed and managed. And then we'll kick in and go through how MVD, Marburg viral disease, is in pregnancy and breastfeeding. And we have a short one slide on prevention and also a take-home message and the references. So as we are all aware, we know that this Marburg virus disease is a hemorrhagic fever and is very fatal in humans. And it actually has a twin, as I could say, it's Marburg virus and Rwanda virus, which lie in the species of orthomarburgovirus, marburgians, from the family Viroviridae family, or as you mostly read through the Marburg, we find that they are mostly called the firoviruses. So these are the most common agents of Marburg viral disease, and as we have seen, they have a case fatality ratio of up to 88%. From the experience, from what we have already seen, that we've seen that now with early patient care, we can reduce this fatality ratio to less than this 88% as has been usually known. So as I've said, even if these hemorrhagic fevers are caused by different viruses, Ebola and Marburg disease usually present the similar picture clinically. And as we know, they're both rare and they have the capacity to cause severe outbreaks with high fatality rates. So the transmission is basically through human-to-human transmission via a direct contact. If one has a broken skin or mucous membranes with the blood secretions from the organs of an infected person, especially even in the surfaces or materials such as beddings, clothing, if these have been contaminated with the infected fluids, then there is that human-to-human transmission via a direct contact. So it's good to know that people cannot transmit the disease before they show symptoms, and they can remain infectious as long as their blood contains the virus. The incubation period is between 2 to 21 days, just before the onset of symptoms. So this is just showing us the timeline of this virus infection. We have we have the initial from where there is the viral exposure to the day of showing symptoms. As we've seen, the incubation period can range between 2 to 21 days. That is an asymptomatic, non-infectious incubation period. It can be between 2 to 21 or 5 to 11 days. So as soon as there is a showing of symptoms, then it becomes day 0 of the illness. So this this graph is just showing us the timeline in changes, especially in the symptoms, management, even the laboratory tests. So it's basically showing us the changes, the way it happens until the patient is cured or the patient is dead. So if we continue, the symptoms, as we've already had or seen, is that one begins to have abruptly striking high fever associated with a severe headache and severe malaise. Muscle aches and pains are also a common feature, and severe watery diarrhea, abdominal pain, cramping, and nausea, vomiting can begin on the 3rd day. We will see that this Marburg virus is actually commonly called a gastrointestinal disease because it causes this severe watery diarrhea. And mostly patients die because of dehydration from this GI loss. So from day 5 is when the patient starts showing hemorrhagic manifestations, including hemoptysis, or even showing merena, bleeding from nose and gums. Even at the venopuncture sites, it can also be observed starting from day 5. This is where also there is involvement of the central nervous system that can result in confusion, irritability, and aggression. So these symptoms, as you will see, they are very common even in pregnant women. We will say that they can mask even other diseases. It does not live around the pregnant population, because the symptoms like muscle aches, is severe malaise, abdominal pain and cramping, these are common symptoms that we encounter during pregnancy. So they are quite similar. So it's going to quite be difficult to diagnose because, as I've already been saying, it is very difficult to clinically distinguish this MVD from other infectious diseases such as malaria, typhoid fever, shigellosis, meningitis, and other hemorrhagic fevers. So confirmation of symptoms can only be done through diagnostic methods. There are very many, but what I've realized that is being done here at RBC is this reverse transcriptase PCR assay. So these are other diagnostic methods, but this reverse transcriptase PCR is the one that is commonly done, especially here in RBC. So treatment and vaccines, as I said, or as we most know, there is no approved vaccine for MVD, but treatment is basically supportive, early intensive supportive care, including rehydration and treatment of specific symptoms, usually improve survival. As I already said, there is no licensed vaccines or treatments for this Marburg virus. And currently, there is this company from the US, Sabens, that has released the current vaccines that we are using in our country. It's a single-dose vaccine that is in a phase 2 trial currently in Uganda and Kenya, that since 2015, if I remember well. and it has not shown any safety concerns that have been reported to date. So death from this firovirus infection usually occurs between 1 and 2 weeks after onset of symptoms, and it results from persistent circulatory shock and multi-organ failure that with marked hepatic and renal dysfunction. So as I was saying, we've, as of 24th October is when we started receiving vaccines. The first batch was about 700 doses of this trial vaccine. And as of yesterday, we've already received about 1,302 vaccine doses that have been administered. You have to keep in mind that this vaccine is contraindicated in pregnancy and breastfeeding mothers, and of course, those planning on getting pregnant. This includes for both men and women. So currently, there are some antiretroviral medications that have been used as emergency in the treatment of MVD, including remdesivir, favipiravir, and gardasil, and it has shown that remdesivir has a broad spectrum antiviral activity against multiple viral antigens. So even if the safety and efficacy of this medication is not yet known in pregnancy, it has been shown to decrease the mortality rate among non-pregnant adult patients or in non-pregnant populations. So they have to be carefully considered given that they have the very high mortality among the untreated population and the near total fatality among fetuses of affected and treated mothers. So here it's just a balance of severity. So if it has remdesivir has shown to be effective, so at one point we'll have to, as we will see that the fetal mortality rate with this infection is very high. So at one point, using these drugs can be very helpful. You have to keep in mind that they are not specific for Marburg viral disease. So for this Marburg viral disease in pregnancy and breastfeeding women, as my senior Dr. Gashema introduced, there is very little information available concerning this virus in pregnancy. But it has appeared that it has similar presentation with the Ebola virus, and MVD infection is associated with an extremely high maternal and fetal mortality rate. So the information got is only case reports, and most of them are actually comparing with the EV virus or EV disease, the Ebola virus. So they compare the effect of this Ebola virus in pregnancy the same as Marburg virus in disease in pregnancy, considering they present similarly. So most of the information is actually based on the outcome from the infection of Ebola. So this is a study that was published in 2019. So as of course, this one was also saying that the initial report of this virus was derived from the outbreak that happened in the DRC in 1998, 1999. And it is believed that 3 pregnant women with this Marburg viral disease were reported, and all of them died. And of course, the infection was lethal to their infants. Here, one woman had a miscarriage and another delivered an infant who died 7 hours after birth. So even if they say from this one, they conclude that it has 100% case fatality rate among infected mothers and their infants. So from the same study, also it was shown that these pregnant women with Marburg viral disease, the same as Ebola viral disease, are at a high risk of having spontaneous abortion and stillbirth. And as of course, EVD Ebola is associated with pregnancy-related hemorrhage, and although it has not been reported, it can also probably complicate MVD infection. Remember, the presentation or the symptoms, they are all hemorrhagic fevers, So that's why they compare the two. And it is that from the number of reports that I've done, they confirm that the hematogenous spread of this firovirus infection through the placenta is the most common source of fetal infection, as high viral titers have been detected in placental tissue, not only for Ebola, but also for other hemorrhagic fever viruses. So we'll find that because of the placenta, that's why the neonatal or the fetal outcome is called close to zero, because the mortality rate is nearly 100%. So this is what I was saying. Pregnant and breastfeeding women are particularly vulnerable because of the physiological changes that occur during the pregnancy, and of course, the immunity that is a little bit suppressed. And regardless of the maternal survival, the fetal loss rates are nearly 100%. And remember, this is with or without maternal death. So it means that if there is a maternal survival, still, even if they are still pregnant, the fetal loss is nearly 100%. So this is most likely they correlate it with the possible cause that because there is unchecked transplacental and hematogenous viral spread. And it is with this, because it is with this that high fetal loss rates support the placenta as a reservoir that is very difficult to eradicate this firoviral infection. So persistence of these firovirus, including MVD, has been documented in pregnancy-related fluids, that is amniotic fluid and tissues, placenta, the cord, and of course the fetus. The fetus in this case will also be considered as a tissue. And even if there has been clearance of the virus from the blood. So evolution of pregnant women, evaluation should be basically done by the Marburg response-trained healthcare providers, and of course with an obstetrician. And the clinical management should be derived from these three things. One is a risk of exposure, symptom history, and of course an obstetrical evaluation. We will see that pregnant women do not necessarily, if they are infected, if they are confirmed with MVD, they do not necessarily need to be evaluated by an obstetrician. They will only need these Marburg response-trained healthcare providers. So the treatment in women with acute MVD, of course, it is the same as in a non-pregnant population. Early aggressive supportive care is the mainstay, and this includes the fluid resuscitation, electrolyte correction, glucose monitoring, and of course, the treatment of potential co-infections such as malaria, bacterial infections, and these strongyloids parasites, nutrition support, and supportive care. They should also be managed like any other patient in the ICU. Being pregnant does not rule out or deny them the fact that they can be managed in an intensive care unit. So this is also a review that was done in the management, and the review was basically focusing on the Marburg and Ebola. They used the knowledge of the disease in non-pregnant individuals and pregnancy-specific data to inform or to derive a management protocol. So it was also, as I was saying, they need an early aggressive supportive care, which is the mainstay of this firovirus infection management with massive fluid resuscitation. So as I said, regardless of the maternal survival, the fetal loss rates are nearly 100% in firovirus infection. And this is likely resulting from, of course, the unchecked transplacental and hematogenous viral spread, as I mentioned earlier. So they concluded that the management of this firovirus infection in pregnancy should focus on stabilizing the mother first with intensive monitoring and aggressive fluid and electrolyte repression, as well as maintaining strict infection control to minimize transmission to others. So there will be a need of about 5 to 10 liters per day, or they can be given intravenous or oral fluids. This is just given to maintain the saturating blood volume in the setting of ongoing gastrointestinal loss. So if a pregnant mother is confirmed with MVD, then of course, like any other patient, maternal vital signs should guide initial management. Of course, as already mentioned, with massive fluid resuscitation. And as also said, they require about 5 to 10 liters. And monitoring and aggressive correction of electrolytes, especially hypokalemia, because of the GI loss, acid-base disturbances, and other electrolyte abnormalities. And antiemetics and antidiarrhea therapy are safe in pregnancy, thus they are recommended. And of course, blood product transfusion can also be beneficial. So for the women who are not in labor, as I said, should not necessarily be evaluated by OB team unless there is an obstetrical complication such as vaginal bleeding or they are in labor. That's when an OB team can be needed in such cases. And of course, treatment should proceed similar to other non-pregnant patients. And women who have recovered from this MVD with a viable pregnancy should be considered high risk. Remember, the placenta, the cord, the amniotic fluid, even the fetus itself are considered to be very infective, even if the maternal serum has tested negative of the Marburg. So IPC measures starting at 36 weeks gestation should be applied to mitigate risks of adverse events and of course minimize transmission risk. And admission can be to an MVD treatment center or a similarly equipped facility at 39 weeks with planned induction of labor between 39 and 40 weeks, of course, with full IPC measures. And if a mother presents at or after 39 weeks and they are in labor, the approach should be to stabilize the mother first in a well-equipped facility. So again, following recovery, it is important to offer pregnant women comprehensive counseling on the risk of adverse pregnancy outcomes and pregnancy management options. Remember, we've seen that the fetal loss here is nearly 100%. So mothers need to be counseled on the risk of pregnancy outcomes. So the baby the mother can have an IFD, can have an intrauterine fetal demise, or the baby can die even in the neonatal period. So here, mothers need to be counseled comprehensively about the risk of adverse pregnancy outcomes. So if they opt to continue pregnancy, they have at least they have been already told about the outcome, and of course they have to understand that not only having an IFD but also a spontaneous abortion for those that have those that are in the early first trimester or early second trimester, they can also present with preterm labor. So moreover, they should also be informed that there is a risk of transmission to others if they're exposed to pregnancy-related fluids, the amniotic fluid, the placenta, or the fetal tissues. So here, labor should not be induced, and invasive procedures should not be done for fetal indications in pregnant women with acute Marburg viral disease. And PPE, e.g. double gloves, face mask, gown, or recovery, I mean, these PPEs should also be put in place. And of course, there should be a pre-assembled delivery box or kit, or even delivery room. That's a room that has everything that one would need in case of a delivery. There is a delivery box kit or even a PPH prevention kit. Like everything should be in one room. And even after delivery, then that room should be fumigated thoroughly. Spontaneous vaginal delivery should be anticipated. And where possible, you have to limit vaginal exams and invasive procedures, especially instrumental vaginal deliveries and episiotomies. Remember, this virus is very highly infectious. And as we have seen, even if the mother has tested negative, but remember the amniotic fluid, the placenta, even the fetus itself will still be highly considered as infectious. And of course, you allow the woman to go through spontaneous labor without interruption. And there is no need to perform artificial rupture of membranes. Remember, we have to minimize the risk of transmission of this firovirus. So if the baby is born still, there is no need to cramp and cut the cord. You can just deliver the baby, the cord, and the placenta as one. And products of conception should be tested for this MVD in accordance with the established recommendations. And of course, given the poor pregnancy outcomes that is associated with MVD, then psychological or psychosocial support should be offered to the mothers. So as already mentioned, invasive procedures should not be taken in the event of fetal distress in pregnant women with acute Marburg viral disease. For example, if there is a need of cesarean delivery here, it is not recommended if it is going to be done for the sake of the fetus. So if there is a fetal distress in pregnant women, they do not recommend to be aggressive, because as we know, the risk of transmission, as we've seen, is very high in such cases. So at one point, they also recommend that as such, fetal monitoring during labor is not really necessary. Remember, keep in mind, this is because of the poor outcome of the fetus. The fetal loss is nearly 100%. So there's no need monitoring labor or doing these invasive procedures. So for the case of breastfeeding, a woman who has recovered from Marburg and has been cleared of the viremia and wants to continue breastfeeding, they're recommended to wait until at least they have had 2 consecutive negative tests, Marburg tests and breast milk test, because even the breast milk can still present this virus for at least, and this test, negative consecutive tests, can be done within a range of 24 hours. And during that time, the woman has to understand that the child should be given formula. And infants who are younger than 6 months of age should also be provided with formula. So as we know, prevention is only by these personal protective equipments, and we should be careful and compliant on how to use these PPEs. And of course, availability of soap and water, hand washing, even alcohol hand gel in our settings, and supplies that have been used for patients with the infection should be disposed whenever possible, and the use of sharps should be minimized. So human remains, especially the fetus or the newborn, should be handled with care, because they are still infectious. And of course, autopsies are also not recommended. They should be avoided unless there is a high need of doing so. So as a take-home message, we understand that this MVD is very virulent, and it can cause this hemorrhagic fever, whether pregnant or non-pregnant populations. And of course, there is no currently available treatment or vaccine, except for the trials, the vaccine trials that are in place. And pregnant and breastfeeding women are particularly vulnerable to this disease. And regardless of the maternal survival, the fetal loss rates are nearly 100%. And of course, the virus can remain detectable in amniotic fluid, the breast milk, the fetal tissue after maternal recovery. So that is if the mother has been cleared of the viremia, then the virus can still be detected in the pregnancy fluids, like amniotic fluid and fetal tissues. And of course, we have to keep in mind that proper infection control precautions should be taken when managing convalescent pregnant people. Convalescent pregnant people, these are mothers that are recovering, even if they are negative, but they are still pregnant, they are still carrying the baby or the amniotic fluid, even the placenta that is very highly infectious. So proper infection control precautions should be taken. So I thank you very much. This is little that we had, and we welcome any comments. Thank you very much for your attention.
Yeah.
Thank you, Dr. Gerard. I think those who on the group who are not muted, they can mute themselves and unmute when they have to answer some question or if they have some questions. Hamis and Prof. Diomed, they can mute themselves. Thank you. So anyone who has question, supplement is welcome.
Good evening, everyone. My name is Aude, and I have a question for the doctor who just presented us the Marburg Viral Disease, regardless, like women who are pregnant or women who are breastfeeding. I would like to understand why is it not indicated to induce mothers who are who have the Marburg Viral Disease. Thank you very much.
Yes, thank you very much for your question. So it is not indicated because, as we are aware, if they are still in the acute phase of the disease, then they are infectious. So we have to limit or mitigate the risks of transmission through that process. And remember, if we induce and they start labor, if they are not really indicate when induction of labor is not really indicated in such cases, then you can increase the risk of exposure through the pregnancy related fluids or even the pregnancy related tissues. So induction is not really recommended unless it is no any other option left. And remember, if they are still in the acute phase of the infection, then they need to first be at least managed. The maternal aspect needs to be stabilized first and managed first, and then proceed with other management options. Maybe my senior Dr. Gashema can add something else on that.
Thank you very much. I think where she have a question is about induction for fetal indication. Like if,
Yes.
for example, you have like abnormal fetal heart rate, you don't have to induce the labor or do cesarean section in the sex to save the baby, because as we have seen of the baby
message.
Yeah, Marburg.
Gutekereza ko ari Marburg nabaze
Iki sinshobora kugisoma nki.
Hello. Alliance Rutebuka. Please, Hamis, can you unmute yourself? Thank you. I think Professor Diomed has raised the hand. Floor is yours, Prof.
Thank you all. Thank you, Dr. Gashema. Thank you, Dr. Gerard, for the presentation. Unfortunately, I cut it somehow late, but if I understand well, it's just like a kind of advice or question I'm asking. Look like in case of acute phase of the disease, the fetal loss is almost 100% always, so no need to do anything. So in such cases, I'm just even wondering, if we have a pregnant woman who has tested positive for Marburg and needs treatment, why should we admit her even in a maternity ward? Why not in a treatment center? So we should not even, because we should not care at all about the fetus, because 100% is going to be lost. So it's better to try to do anything else, whatever we can for the mom, and it should be in a treatment center, not even in a maternity. So we should not prepare ourselves to receive any patient. Is it correct? Thank you.
Hello, Prof. I think Gerard talked about it. Cases tested positive for Marburg have to be transferred in treatment center. And if possible, if they can avail even a room with all equipment for delivery in case in treatment center, it's advised than just bringing patient at CHK at Kanombe, so that even delivery can be done in treatment center. Because if she's delivered still in CHK where they have like 2-3 delivery beds, we know that these amniotic fluid can spill all over even on the walls, and these can be is contaminated, can be the source of infection for other like health mothers. So I think he presented about it before about this. Thank you.
I have another question, if I may ask. As a health professional, what should we do for us? Like, we can talk about it, we can do prevention, but can you give us other tools that we can use maybe to help those women? This is my first question. And my second question, you said that, like, as Dr. Diomet just said, that there's a risk that there's a mortality infantile of the baby for 100%. Do we have some chance of survie if we give those medication that you said in the beginning of the presentations? Thank you very much. Thank you.
I think the tools for the prevention is just the basic, proper handling of the PPEs while dealing with such cases. So, and as Dr. Gashema mentioned as well, even if, let's say, the mother has reached the point where there is need of to deliver her, to conduct labor, then that room should be very equipped with a very good delivery kit or delivery box. Even you anticipate, even if there is supposedly to be a PPH, then there has to be a kit to prevent PPH. Like, everything has to be planned and put in that specific room for such patients. And I think, the basic tools are those: proper PPEs, and of course, that room should only be entered with very few people to minimize the risk of transmission to a lot of healthcare providers, and of course, keep that to delivery kit, and of course, anticipate if there is a PPH, there should also be a PPH prevention kit. And of course, after the delivery has been conducted, there has to be a proper fumigation, even on the walls. Even a small splatter of amniotic fluid, if it goes on a chariot or on the wall anywhere, it should be properly fumigated or cleaned. For your second question, I don't quite remember well. If you can repeat again.
So I was saying, my second question, it was about, the fact that you're saying that we have 100% of mortality of the baby. do we have a chance maybe to, if, for example, imagine like we have a woman, she's like, let me give an example. Like we have a woman, she's at 37 weeks of pregnancy, and then she contracted the Marburg disease. And then we put her on prevention, giving her the medication. Do we have a chance to have a survey that the baby survive or not at all?
So as I started, the data that we derived from all this, Marburg Viral Disease is still a mystery to most of us. The only data that is available is the comparison with the Ebola viral disease, considering they are all hemorrhagic viral diseases. So from what I've read is that even if the baby survives the delivery period or even the intrauterine period, the highest one has survived is 19 days in the neonatal period. So we'll contact probably our fellows from the neonatology unit here at Kanombe. They have also done a guideline that shows how to manage such patients, babies who are born from infected mothers. How do you handle that? As we know that the fetal loss is 100%, so the management there is supportive. The infection is very lethal to the fetus in such cases. The only finding that I found is the baby survived for only 19 days after delivery. So even if they survive the intrauterine period, then the neonatal period is not, they're not going to survive the neonatal period. So the only thing you can do here is the supportive management.
So thank you, Gerard. What I can add on is we have seen, like here in Rwanda, we have seen two first cases that had Marburg, and they has been admitted in ICU, intubated, and they have been recovered. And before, there was no cases that has been recovered from ICU. So we can't say never. We can't say maybe this baby, though is surviving, this baby, those like previous baby all has been died. So if the baby is delivered alive, we have to have a pediatrician, neonatologist to do the follow-up. We never know. The baby might survive, because as we said, is based on case series. It's not a proven evidence. Even for treatment, this treatment, the antiretroviral drugs that they are using, it's not specific for Marburg. It's just trial. They are trying to see whether they might have good improvement. And we have seen that after Rwanda, they initiated these drugs, interferon, the outcome, like the survival of patient who has Marburg, has been improved. So we can't say 100%. We reject this pregnant mother with saying that the baby 100% they will die. So we can still give their chance, try to help until this baby might even die. So that's what maybe I can say about it. Thank you. I can see Charles has question. Charles, the floor is yours.
Okay, thank you so much. I just wanted to ask for the mothers who has recovered from MVD, for the next pregnancy, at which time do we advise them to get pregnant again? And I just want also to ask, is there any preventive measures to give them for preventive measures? Thank you.
Well, for the recommended time that you can give pregnant mothers so that they are able to, get pregnant, there is no documented time, but from what I've read with the follow-up that they did with the survivors of the Ebola virus, they found that after 1 year, when they have delivered, they still had no, the viremia was still negative of the virus, of the hemorrhagic virus, and after they got pregnant, they also tested, they did the amniocentesis and it was still negative. So the only positive was that they did IgM and IgG, and the IgM was still positive, but the IgG was negative. So I am not sure of the exact recommended time, but as long as the mother is been cleared of the postpartum period and the viremia is negative, so I think from there they can, if they get pregnant, they can be followed cautiously.
Okay, thank you. So the next question was that, is there any preventive measures to be given to them when they become pregnant?
So when they become pregnant, that's let's assume they become pregnant after, let's say, 6 months after they had tested the previous infection, or 1 year. So the only recommendations you can give is like in any other general population. So I think you can tell them to be careful. And of course, as I said earlier, cautiously monitoring them to check the presence of the Marburg Viral Disease in their blood. And of course, if they are in a setting where you can easily test, or you can do amniocentesis, you can test for the baby and see if the amniotic fluid or even the fetus carries the infection. So I think when they get pregnant, there has to be a cautiously follow-up of such mothers to detect or to rule out a possibility of a recurrence of the infection. But once they are cleared, I believe they do not have the infection.
Hello, I think those who have been cleared from infection, there is no special measures for when they become pregnant. They will know any special care. They should be treated as general other pregnant mothers. But maybe the question was based on those who had vaccine. I think currently those who have been vaccinated, they have to get pregnant at least 9 months, 6 months, if I remember well, after the last injection. And this is applicable also for men. But these education are given for those who are being vaccinated. So it's not those who have been declared cured and then later become pregnant. They should not be treated as those who had like active Marburg diseases.
Hello, guys. Probably as there is no one else raising the hand, I think all of these things are still assumption and everything. We don't have evidence based, especially for the Marburg. Even the little information we have is from Ebola. Last time we had a talk from Dr. Kakema from Uganda. Uganda had some kind of small outbreaks, but yet we don't have really good evidences about those who recovered, those who will get pregnant later on. So we still have the assumption. And the only information we get is from the main bigger outbreak from Ebola. And since they are related, we just assume. So for the the vaccines, it's not yet there to know exactly what to do later on. The 24 weeks that were provided is just to think that we don't know exactly what is happening. So let us wait and see what are the different side effects, the different outcome of those vaccinated. So it's still assumption. We don't have really evidence-based articles, medicine that we should use. So it's still under investigation. So this is what I had to say. I don't think we should not really just think that there is something we can just get, especially for Marburg virus disease. The only information we are trying to use is from Ebola, which is actually almost the same. Thank you.
I think if no more question, we can end the talk. And thank everyone for participation. Thank you, Prof. Diomed, for your inputs, and Gerard. And thank you, Parfait, for organizing this. So see you next time.
Thank you.